So we go ahead to next paper, the diagnostic yield of investigations in ocular myasthenia gravis presenting as ptosis. The presenting author is Dr. Akshay Nair. Dr. Akshay Nair, please.
Yes, I am a ratified member. My topic is titled The Diagnostic Yield of Investigations in Ocular Myasthenia Gravis presenting as unilateral ptosis. Myasthenia is a common autoimmune disease which presents very frequently to oculoplastic surgeons as ptosis, which is the most common presentation. There are multiple investigations, clinical and invasive, which are used to diagnose myasthenia, the eyes test being the most routinely employed one. It has a high specificity and sensitivity for ocular myasthenia gravis. The Neostigmine test is an invasive test which gives real-time results but requires the supervision of an intensivist. In generalized myasthenia, it has a higher sensitivity, but very few reports have studied its utility in isolated ocular myasthenia gravis. Single fiber EMG, although the most sensitive test, the sensitivity is restricted to generalized myasthenia with a far lesser sensitivity for ocular myasthenia gravis, as is the case for acetylcholine receptor antibodies, with reports showing as low as 30% of the patients with isolated OMG reporting the presence of antibodies, in addition to being expensive. So there are a variety of tests with varying sensitivities. There are very few papers that have investigated the utility of all of these in isolated ocular myasthenia, even fewer that have focused on ptosis, which is the area of interest for us oculoplastic surgeons. So therefore, this study was designed to assess the diagnostic yield of various investigations employed in cases of ocular myasthenia gravis presenting as unilateral ptosis. We reviewed the charts of 37 consecutive patients of ocular myasthenia gravis who presented with unilateral ptosis in a period of 2 years. The parameters documented were eyes test, single fiber EMG, Neostigmine test, and acetylcholine receptor antibodies. The inclusion criteria included that they should not have been treated for myasthenia earlier. The mean age in our cohort was about 45 years with equal sex distribution. The mean duration of symptoms was a little over a year, and the mean follow-up period was 11.8 months. The eyes test was seen to be positive in 34 out of 37, giving it a sensitivity of 91.9%. All the cases were conducted by a single observer and were photographed, and the eyes was placed for no more than 2 minutes to avoid false negatives. Neostigmine test was positive in 21 out of 37 patients, giving it a sensitivity of 56.8%. It, of course, was done in the OR with the anesthetist with an initial dose of 0.5 milligram IV. A single fiber EMG was conducted, and it was ensured that the orbicularis oculi was also assessed during the investigations. All of them were conducted on the same Dantec keypoint EMG machine and were interpreted by the same neurophysiologist to ensure uniformity. It had a sensitivity of 59.5% with only 22 out of 37 patients showing a positive result. Antibodies were seen in 17 out of 37 patients with a sensitivity of 45.9%. So to tabulate, the highest sensitivity was for the eyes test, followed by single fiber EMG and the Neostigmine test, and the least for antibodies. So if you were to put aside eyes test and put a Venn diagram, we see that only 9 patients had all 3 investigations positive in all cases, which then led us to draw up a list of variables that could affect the outcome of these investigations. When we consider gender, none of the tests showed any significant variation on the basis of sex. Now, because in our cohort the average age was 45, we split up the group into two groups, those below 45 and those above 45. And single fiber EMG had a significantly higher rate of positivity compared to other tests in those who were more than 45 years of age. The mean duration of symptoms in our group was a little over a year. So similarly, we split up the patients into 2 groups, those with symptoms for less than a year and those with symptoms for more than a year. And when we compared them, we saw that Neostigmine tests and antibodies were significantly higher in those who had a history of ptosis for more than 12 months. Past history of diplopia was seen in 9 patients, and 8 of these 9 had positive findings in single fiber EMG, which was statistically significant compared to the other investigations. Ptosis was also graded by a single oculoplastic surgeon. This was, of course, at presentation, which has a potential pitfall because of diurnal variation seen in myasthenia. But based on the ptosis at presentation, if we see mild ptosis, single fiber EMG had the highest utility. But when it came to severe ptosis, it was anti-acetylcholine receptor antibodies which had the highest sensitivity. So when we compare the results with those already present in literature, the eyes test results are comparable with similar results in previously published paper. They are within the range of comparison for antibodies and for electromyography, but Neostigmine test was significantly lower in our case, in our series, as compared to this large series published from NIMHANS in India. It also has economic implications, because if every patient were to undergo all investigations, this would set back the patient by an average of 17,000 rupees, which makes a strong case to maximize, for tailoring these investigations, to maximize the diagnostic yield. So to summarize, the ICE test had maximum utility in predicting myasthenia across all age groups, except in severe ptosis at presentation. In those with a history of ptosis for more than 12 months, the first-line investigations could be antibodies followed by the Neostigmine test. In those who were older than 45 years and in those with a history of diplopia, single-fiber EMG could be considered to be the first line of investigation. And those who presented with severe ptosis, antibodies could be considered. ICE test should be performed in all cases suspected of myasthenia that present with unilateral ptosis. It may be useful to consider age, duration of symptoms, and previous history of diplopia, and the severity of ptosis at presentation while deciding which investigation needs to be done first. This is the first study from India to study outcomes of investigations in ocular myasthenia presenting as ptosis. Our limitations included a small study group and a non-progressive study which did not check the conversion from ocular to systemic myasthenia. Thank you.
Thank you, Dr. Akshay.